Most families don't see it coming until the day it arrives. Mom falls, breaks her hip, spends 5 days in the hospital, and then the hospital caseworker sits down with the family and says she needs skilled nursing care for rehabilitation before she can go home. And the family thinks, okay, Medicare covers nursing homes, right? So we're fine. And for the first 20 days, they actually are fine. Medicare covers it completely, no cost to the family. But on day 21, the bill changes, and it changes again on day 100. And somewhere between the fall and the day Medicaid finally starts paying, if it ever does, families can lose 6 figures of savings in a matter of months, with almost no warning and almost no plan. That gap between the start of care and Medicaid eligibility is the subject of today's video. It's the gap nobody talks about until you're standing inside it. And unlike some of the other things we've covered on this channel, the gap doesn't have one clean solution. It has a sequence of decisions, and each decision either costs or saves money depending on the order you make them in. By the end of this video, you'll understand exactly what that sequence looks like, what each funding source actually covers and when it stops, and, most importantly, what the families who navigate this well do differently from the families who don't. And before I say another word about any of this, I want to say the thing I say in every video. I'm not your lawyer, I'm not your financial advisor, and nothing here is legal or financial advice. What I am going to do is hand you the clearest map I can for how this works. Because understanding the territory is the first requirement for navigating it without losing everything. Let me start with the single most dangerous misconception in all of long-term care planning. Say it with me, even if you think you already know it. Medicare does not pay for long-term care. It covers short-term skilled rehabilitation. That distinction is the one that costs families the most money, because almost everybody confuses the two, and by the time they figure out they were wrong, the clock is already running. Here is what Medicare actually covers in a skilled nursing facility. After a qualifying hospital stay of at least 3 consecutive inpatient nights, and observation status does not count, which is its own trap we'll get to in a moment. Medicare covers up to 100 days of care in a skilled nursing facility per benefit period. Days 1 through 20, Medicare pays 100%, no cost to the family. Days 21 through 100, Medicare still pays the majority, but in 2026, you owe $217 per day in coinsurance. Do the math. That's roughly $6,500 per month coming out of your pocket even while Medicare is covering the rest. And then day 101, Medicare stops entirely. All costs, every dollar, on you. Those are the 3 cliffs. Now here is the fine print that the cliff hides. Medicare's rehabilitation coverage requires that the person still needs skilled care, physical therapy, occupational therapy, wound care, IV medications, every single day. The moment the clinical team determines the person has plateaued and doesn't need that level of daily skilled care anymore, Medicare coverage can end, even if they haven't reached day 100. It could end on day 30. It could end on day 60. The 100-day number is a ceiling, not a guarantee. Families who plan around "we have 100 days" often find the coverage ends much earlier. And the observation status trap. This is one of the cruelest quirks in Medicare. If your parent was admitted to the hospital but technically held on observation status, which is a billing designation, not a clinical one, their hospital stay doesn't count toward the 3 inpatient nights required to qualify for Medicare nursing home coverage. You can spend 4 days in a hospital under observation status and have 0 Medicare coverage for the nursing home that follows. Hospitals are required to notify patients when they're on observation status, and if this happens, you need to ask immediately before discharge whether the status can be changed to inpatient. Sometimes it can, sometimes it can't. But asking is always worth doing because the difference is potentially tens of thousands of dollars. So let me walk you through what the actual sequence looks like for a family that hasn't planned. I'll call the family the Harmons, composite. Details changed, the way I always do these. Ruth is 81. She lives alone. Her daughter Sandra lives an hour away. Ruth falls in January and fractures her hip. 5 days in the hospital, hip surgery, then discharged to a skilled nursing facility for rehabilitation. Medicare kicks in. Sandra is relieved. For the first 3 weeks, 0 out of pocket. Then week 4 starts, and the bills begin. $217 a day, every day. By week 7, Medicare's physical therapist says Ruth has made good progress and recommends stepping down to a less intensive level of care. The daily skilled care requirement is no longer met. Medicare coverage ends at day 54, not day 100. Ruth can walk again with a walker, but she can't go home. She needs help with bathing, dressing, meals. She needs a custodial level of care, and custodial care is exactly what Medicare has never covered. Now Sandra has to figure out how to pay for a nursing home at the private pay rate. According to the most recent Care Scout data, the national median cost for a semi-private nursing home room is $9,500 a month. Not $9,500 for the whole stay, $9,500 every single month. Ruth has $82,000 in savings. Sandra does the math quietly on her phone on the drive home. 8 to 9 months. That's how long the money lasts before it runs out. And then what? That "and then what" is Medicaid. But Medicaid has 2 requirements that Sandra doesn't fully understand yet. The first is an asset limit. In most states, Ruth would need to spend down to roughly $2,000 in countable assets before Medicaid will pay. In most states, her home is exempt during her lifetime, but her savings are countable. So the savings will get spent on legitimate care costs, which is the right way to spend them, until she qualifies. The second requirement is time. Even after Ruth spends down, the application process takes time. In many states, it takes 60, 90, even 120 days to get a Medicaid application processed. During that time, the bills keep coming. Here is where this story splits depending on what Sandra knows. In the version where Sandra doesn't know much, she just pays the nursing home's private pay rate, $9,500 a month, from Ruth's savings, watches the account drain, applies for Medicaid when the account hits nearly zero, and then waits another 2 to 3 months in a kind of financial limbo while the application processes. By the time Medicaid is approved, Ruth's savings are gone, and there's nothing left to show for $80,000 except a clean bill to a facility. In the version where Sandra knows more, a few things are different. First, Sandra learns something called retroactive Medicaid eligibility. In most states, Medicaid can cover up to 3 months back from the date of application, meaning if Ruth would have qualified 3 months ago, Medicaid will pay for those months retroactively. So Sandra applies earlier than she would have otherwise, and the retroactive coverage clause backs some of what the family paid privately. I want to be precise here. This retroactive window is currently 3 months in most states, but federal legislation signed into law is going to shorten it to 2 months, starting January of next year, in 2027. So if retroactive coverage matters in your situation, sooner is better than later. Second, Sandra learns that the spend down doesn't have to just be writing checks to the nursing home at the full private pay rate. There are legitimate spend down strategies that don't violate Medicaid's look-back rules, paying off debt, including the mortgage on the exempt home, making safety modifications to the home, purchasing an irrevocable prepaid funeral plan, which is an exempt asset, replacing a genuinely worn-out vehicle, catching up on home maintenance that's been deferred. None of these purchases are tricks. They're legitimate uses of money that happen to reduce countable assets while actually benefiting the family. What families cannot do is gift the money to children or transfer assets for less than fair market value. That triggers the look-back penalty we covered in video 1. But legitimate spending is always permitted. Third, Sandra asks the nursing home a question most families never think to ask. Do you have a different rate for Medicaid pending residents? Some facilities will negotiate a bridge arrangement where they accept a lower interim rate while a Medicaid application is processing, rather than the full private pay sticker price. Not every facility does this, but it's worth asking directly. The worst they can say is no. Now I want to bring in one more funding source that sits between Medicare stopping and Medicaid starting, one that not enough families know about: long-term care insurance. If your parent purchased a traditional long-term care insurance policy at some point in the past, this is exactly the moment it exists for. Benefits typically trigger when a person can't perform 2 or more activities of daily living: bathing, dressing, eating, toileting, transferring, or continence, or when there's a cognitive impairment like dementia. The policy pays a set daily or monthly benefit amount for the covered care. For families who have it, it can cover months or years of the cost gap, preserving savings that would otherwise drain entirely. The challenge is that the majority of people don't have it, either because they couldn't afford the premiums, couldn't qualify medically when they tried to buy it, or simply never bought it. If your parent is still healthy enough to qualify, Buying it now is worth pricing out, though premiums rise sharply with age and health changes. A 55-year-old woman might pay $1,500 to $3,000 a year. The same policy at 65 can cost twice that if she can still qualify at all. There's also a hybrid option that's gained traction: life insurance policies with a long-term care rider, or hybrid life and long-term care products. The appeal is that money isn't wasted if care is never needed. If the long-term care benefit goes unused, a death benefit remains for the family. These products are worth exploring if your parent has a permanent life insurance policy with cash value, because sometimes an existing policy can be converted or exchanged into one of these hybrids. A fee-only financial advisor with elder care experience can help evaluate whether that's worth doing in a specific situation. Now, I want to address the family in the middle, the one where Medicaid may eventually be relevant, but isn't an immediate crisis. Your parent is at home, needs some help, not yet at a nursing home level. This is actually the most important moment in the whole story, because it's the moment when the most options are still open. There's a cost hierarchy worth understanding. In-home care from a paid aide runs nationally around $35 an hour based on CareScout's most recent data. At 8 hours a day, 5 days a week, you're around $6,700 a month, less than a nursing home but still significant. An assisted living community runs about $6,200 a month nationally. Memory care, which is a specialized tier of assisted living for people with dementia, runs a bit higher, typically $6,000 to $8,000 a month, depending on the state. A nursing home, as we discussed, starts around $9,500 a month for a semi-private room and goes up from there, with states like New York and Connecticut running $15,000 or more. Understanding where your parent is on that spectrum today, and which direction they're likely moving, is the foundation of any honest financial plan. For families earlier in the journey who still have several years before intensive care is likely, there are planning tools worth knowing. The Medicaid Asset Protection Trust we've talked about on this channel requires 5 years of lead time, but can protect significant assets, including the home child, from both Medicaid spend-down and estate recovery. The Long-Term Care Partnership Program is available in most states and allows you to purchase a qualified long-term care insurance policy that, once benefits are exhausted, lets you protect $1 of assets for every $1 of benefits the policy paid. So if the policy paid $300,000 in benefits, you can keep $300,000 in assets above Medicaid's normal limit. It's a bridge between insurance and Medicaid that most families don't know exists. And the veterans benefits we covered in video 8, aid and attendance, can pay up to $3,845 a month for a married veteran in 2026. And that money can pay for care during exactly this gap period without spending down family savings. Here is the thing I want you to hold on to, because it's the through line in every video we make on this channel. The cost of not planning is always greater than the cost of planning. A family that starts this conversation 5 years early, when a parent is in their mid-70s and doing reasonably well, has every tool available: the Medicaid Protection Trust, the long-term care insurance purchase, the VA claim filed and the documentation built, the legal documents in place, the spend-down strategy thought through in advance rather than invented in a panic in a nursing home parking lot. A family that starts this conversation the day of the fall has some tools: the retroactive Medicaid application, the spend-down strategies, the Medicaid pending negotiation with the facility. But fewer tools, and more of the money already spent. The gap doesn't have to be a free-fall, but the only way to build a floor underneath it is before anyone falls. Here is your action plan for this week, whether the crisis has arrived or not. If care has already started or is imminent, verify immediately whether your parent's hospital stay qualifies as inpatient, not observation, so you know whether Medicare nursing home coverage applies. File the Medicaid application as soon as your parent may be eligible, because the retroactive window runs backward from the date you file. Ask the facility directly about Medicaid pending bridge arrangements, and list the spend-down items, debts, home repairs, prepaid funeral, so you're spending legitimately rather than just paying the private pay rate on autopilot. If you're in an earlier window, care isn't here yet, but you can see it coming. Price long-term care insurance this year while your parent can still qualify medically. Look into the Long-Term Care Partnership Program in your state. If your parent is a veteran or the surviving spouse of one, start the VA aid and attendance claim now. It takes months to process. and sit down with a certified elder law attorney to map the 5-year Medicaid planning window before it closes. And if your parent is healthy and this all feels distant, watch this video again in 2 years, because the gap between "this seems far away" and "we needed to have done something 2 years ago" closes faster than anyone expects. The families who come into this with a plan don't necessarily have more money. They just started one conversation earlier. This video is educational only. It is not legal, tax, or financial advice. Long-term care costs, Medicaid rules, and Medicare coverage specifics vary by state and change yearly. Always verify current figures in your state and consult a certified elder law attorney and a qualified financial advisor before acting.